spine. And I must tell you that they may sound as controversial as they may sound, but there may be some message for you, and those who wish to take that message are most welcome. So you see here, this is a degeneration of craniovertebral junction. The joint spaces are reduced. There is osteophyte formation here and here. And in the midline, there is ligamentous buckling. And this ligamentous buckling is the initiator of osteophyte formation. You agree? You agree? And these osteophyte formation are a result of ligamentous buckling due to reduction of joint space. The treatment is opening of the joint space and distraction of the facets. And you can reduce the dislocation, and you can remove the osteophyte. Or you can remove the beginning of the osteophyte, or pathogenesis. You attack the pathogenesis of osteophyte. So we wrote this article some time ago for the first time in the literature that there can be degeneration of C1, C2 joint. There can be degeneration which leads to osteophyte formation anterior to the odontoid process. We discussed that joint space is reduced and there is an instability of the joint without any manifest instability. So this retroodontoid osteophyte formation, we said, is due to atlantoaxial instability, and atlantoaxial stabilization is the treatment. These were called pseudo tumor, and various names have been given to this entity, and we said that this is due to the joint problem, distraction of the facet, and treatment is the solution. And after we mentioned this, several other authors in the world have done this kind of treatment. So we said that retroodontoid mass is an evidence of craniovertebral junction instability. We also subsequently reported many articles on this, that there was immediate postoperative disappearance of retroodontoid pseudotumor following facetal distraction and treatment. Retroodontoid cyst-like formation is also an evidence of buckling of the posterior longitudinal ligament in the craniovertebral joint, which is tectorial membrane, and this retroodontoid cyst formation can be reduced by facetal distraction and surgery, and there is an immediate postoperative reduction of this cystic degeneration. This is another retroodontoid cystic degeneration. You see there is a facetal malalignment, and you do facetal fixation. There is an immediate post-op, means scan done after 24 hours of surgery, and the cyst is gone. So there is no point in removal of this cyst by either transoral, lateral surgery, or any kind of surgery. What is required is to hit the point of pathogenesis of the problem, and that is the solution. Similarly, in rheumatoid arthritis, we all have treated rheumatoid arthritis. Alan Crocker, Pule will know, has treated transoral surgery for a long time for rheumatoid arthritis. Rheumatoid arthritis is much less common now, but there is a place for craniovertebral realignment in rheumatoid arthritis. There is no need for decompression or transoral surgery, and this is, we have mentioned in several of our articles, that no need for decompression Instability is the issue, stabilization is the treatment. So this is my article, and you see the facet of C1, facet of C2, and we introduce intra-articular implant, reduction of the dislocation and fixation. The issue of retroodontoid pannus, which is a very commonly described entity with rheumatoid arthritis. You see there is an instability here, and this is postoperative reduction, and this is intra-articular spacer that we have introduced long time ago. So this is the pannus. Now pannus, people like to do transoral decompression, removal, and all those kind of things, but distraction, reduction, and fixation can reduce the pannus completely in the immediate postoperative period. Did you get my point? My point is the pannus is due to buckling of the posterior longitudinal ligament. It is not an inflammatory response. There are evidences of inflammation in the retroodontoid ligament, but you distract the facet, the pannus disappears, and it can disappear in the immediate postoperative period. So quite a different, otherwise you remove the pannus from the mouth and things like that. So then our intra-articular spacer technique, as you know, has been used for a number of situations. The bottom line is understand instability. Understand that instability is the problem and all other issues are consequences of instability. That is the bottom line of understanding. And this is what I want to show you for cervical degeneration. Cervical facets we have never exploited for treatment. My answer to a very important question is, like I said, facet C1, C2 facet is the point of fulcrum of C1, C2 movement. I am saying that the facets of cervical, dorsal, lumbar spine are the fulcrum of all spinal movements. Spinal instability forms the basis of spinal degeneration. Standing human position, disuse, misuse, and abuse of the muscles of the neck forms the basis of spinal degeneration. So my concept is that it is not the disc which is the problem. It is not the reduction in the disc space or reduction in the water content of the disc that is the problem. Problem is you. Like you have not exercised enough. You have not done exercise of your muscles. You have not done all kinds of gyms and all those things. Vertical collapse or telescoping of the spine, which is manifested at the facets, is the issue of spinal degeneration. Whether I sound provocative or whether I sound beautiful, just take it as a new message for you. Take it. Ignore it, but take it. Facetal overriding is the genesis of problem, and buckling of the posterior longitudinal ligament is due to the facetal overriding and osteophyte formation. Ligamentum flavum buckling are the consequences of muscle instability. Disc space degeneration or disc space reduction is a consequence of facetal overriding. This is my concept. Facetal listhesis. Facetal listhesis is the issue in spinal degeneration. We introduced facetal distraction spacers, and this is, for your information, is a technique which has been patented by me, the implants which have been patented by me. So there is some kind of a patent involved, but patent is patent, theory is theory, and philosophy is philosophy. I want to discuss philosophy. Introduction of intra-articular spacer, distraction of the facet, reduces the facetal listhesis and reduces the ligamentum flavum buckling and reduces the osteophyte formation in the immediate postoperative period, and there is a possibility, and not possibility, absolute recovery in the clinical symptoms. So this is the osteophyte. The whole world will come from front, remove the disc, and remove the osteophyte. Osteophyte is not a problem. Ligamentous flavum buckling is not the problem. Problem is listhesis of facets. Distraction of the facet is the treatment, and you can have immediate postoperative period reduction in the osteophyte, increase in the disc space, and the destruction of the ligamentum flavum stretch without manipulating or handling of these structures. Osteophyte formation is not an issue. Disc space reduction is not an issue. These are consequences of muscle instability and facetal overriding. Distraction of the facets can reduce the ligamentous buckling in the immediate postoperative period, and there is a potential for reversal of osteophyte in the postoperative course. Most importantly, clinical recovery can be remarkably effective. So intra-articular spacers can possibly be a revolution in the field of spinal degeneration. You see there is a osteophyte formation, and this is the postoperative, a new disc formation. You see the ligamentous buckling, and you see the ligamentous stretch, and you see the cervical realignment. This is the scan, and you see here, this is intra-articular spacers. You see this is postoperative, the increase in the disc space height, increase in the canalicular height, increase in the facetal height. More importantly, improvement in the clinical condition of the patient. So you can introduce 2 spacers at each level, and you can introduce 1, 2, 3. I have introduced 5 spacers at each level. You please see the increase in the facetal distance, increase in the facetal distance, increase in the facetal distance, increase in the spinal canal distance, stretch of the ligaments, reduction of the osteophytes, and increase in the disc space height. So these are some of the cases, and we have got several cases of this kind. You see the multiple introduction, and this is immediate postoperative period. You can see the facetal spacers inside the spacers and bone graft. So intra-articular spacers is an emergence of a new concept, which can be. I'm not saying it will be. There may be controversies, but it can certainly be a game changer. So you see here there are osteophytes, there are spinal cord changes, and you see immediate postoperative period, and these are, unfortunately, I'm not sure if they match each other. These are the spacers. This is another one. You see C2-3 fusion, this fusion. This is pre-op, and this is immediate post-op. There is the disc has come back. This is pre-op. This is the pre-operative. You see the fusion. You see the ultimate fusion in a distracted condition. You see the fusion, and more importantly, you are interested in the neck movements. They can be restricted. They can be restricted, certainly, but they can be not restricted to an extent that they can trouble the person. So my paper was published as a cover page of Journal of Neurosurgery in 2011, 8 years ago. And recently I have got a patent on this technique and a patent on this spacer, and I now want to promote this technique. There is an immediate, now you see another one, beautiful, just see, forget about patent and forget about this. Disc prolapse, okay? Distract the facet, and you see the arts immediate postoperative reversal of disc herniation following facetal distraction. So this I reported in World Neurosurgery, and this is the scan which is showing preoperative, and unfortunately, let me put my glasses. This is the disc herniation. The entire world will say, come from front and remove. There is no question, no discussion. But there is a possibility of complete reversal in the immediate postoperative period. This is another one, the disc herniation.